So face and neck injuries. That's next. So National EMS Education Standard Competencies. Medicine applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. It's a medical patient. Disease of the eyes, ears, nose, and throat. We will focus on that. Recognition and management of nosebleed. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. We'll be looking at head, facial, neck, and spine trauma. The focus will be on recognizing live threats and dealing with these live threats. We look at the pathophysiology, assessment, and management of penetrating neck trauma and laryngeal tracheal injury. We'll look at the pathophysiology and assessment and management of facial fractures, foreign bodies in the eyes, and dental trauma. Introduction. Face and neck are vulnerable to injury. And when you think about face and neck injuries, it's very simple. Your concerns are going to be, is this injury compromising the airway? Can this injury cause spinal injury? That's it. Is there an airway problem? Is there the possibility for spinal injury? Relatively unprotected positions on the body. Soft tissue injuries and fractures are common and vary in severity. Some injuries are life-threatening. So penetrating trauma to the neck may cause severe bleeding. Open injury may result in an ear embolism. The head, cranium, contains the brain. Most posterior portion is called the occiput. Lateral portions on each side are called temples or temporal regions. The forehead is called the frontal region. Anterior to the ear is the temporal region. You can feel the pulse of the superficial temporal artery. The face, you have the nasal bone, zygoma, which is the cheek, maxilla, upper jaw, mandible, lower jaw. 6 major bones include the nasal bone, 2 zygomas, 2 maxillae, and the mandible. The orbit of the eye is composed of lower edge of the frontal bone of the skull, the zygoma, maxilla, nasal bone, and it protects the eye from injury. So that's the main role of the eye orbit, to protect the eye from injury, but it can be fractured. Only the proximal third of the nose is formed by bone. The remaining 2/3 of the nose is composed of cartilage. The exposed portion of the ear is composed entirely of cartilage covered by skin. I have the pinna, the tragus, and the superficial temporal artery. And you can see where the pinna is on the diagram. The face, about 1 inch posterior to the external opening of the ear, is the mastoid process. The mandible forms a jaw and chin. The neck contains many important structures supported by the cervical spine. The upper part of the esophagus and the trachea lie in the midline of the neck, and the carotid arteries are found on either side of the trachea, and they supply the head, specifically the brain, with blood flow. The larynx, Adam's apple, is located in the center of the neck. Other portion of the larynx is the cricoid cartilage, which is the first cartilage within the trachea that forms a complete ring. Just above the cricoid cartilage is a membrane referred to as the cricothyroid membrane. It is a surgical point in the field for paramedics. And above that, you have the thyroid cartilage, which has that prominence, which is referred to as the Adam's apple. So you have a laryngeal prominence at the top end of the thyroid cartilage. That's what is referred as the Adam's apple. It's more visible in males than females. Just below the thyroid cartilage, you have the cricothyroid membrane. And the thyroid cartilage is open at the posterior end. And just below the membrane, you have the cricoid cartilage. That's the one that forms a complete ring. The trachea, below the larynx, connects the oropharynx and larynx with the main passages of the lungs. The sternocleidomastoid muscles originate from the mastoid process and allow movement of the head. So as the trachea moves down, you'll have the larynx, and it connects the larynx and oropharynx. And the nasopharynx is also connected, and the ear passage is also connected. Hold on, let me backtrack a bit. Okay. The eye, globe shape, approximately 1 inch in diameter, located within a bony socket in the skull called the orbit, composed of adjacent bones of the face and skull, and it protects over 80% of the eyeball. So most of the eyeball is within the orbit. You have the anterior compartment, which is filled with aqueous humor or fluid, and that fluid can be replaced if it is lost. You have the posterior compartment, which is filled with vitreous humor. This fluid, if lost, cannot be replaced. I have the different structures of the eye: iris, cornea, pupil, lens. You have the vein, artery, optic nerve, the retina. Pay close attention to the retina, because the retina is the structure that links the eye to the brain. So if there's a problem with the retina, patient can't see, right? Or if the retina is detached, they won't be able to see. Clear jelly-like fluid near the back of the eye is called the vitreous humor. In front of the lens is fluid called the aqueous humor, which can leak out in penetrating injuries. You have the lacrimal gland, you have the pupil, iris, sclera, white portion. The conjunctiva is the membrane that covers the eye, and it can be irritated or infected, and it can be inflamed, become inflamed. The lacrimal glands produce fluid to keep the eye moist. The sclera is a white fibrous tissue that helps maintain the globular shape of the eye. So the sclera is responsible for the shape of the eye. On the front of the eye, the sclera is replaced by a clear transparent membrane called the cornea, and the cornea allows light to enter the eye. The iris is a circular muscle behind the cornea. The pupil is the opening in the center of the iris, and it allows light to move to the back of the eye. Anisocoria is a condition in which a person is born with different sized pupils. The lens line lies behind the iris, and it focuses images on the retina at the back of the globe. The retina contains nerve endings, and it responds to light by transmitting nerve impulses through the optic nerve to the brain. The retina is nourished by a layer of blood vessels called the choroid, and retinal detachment causes blindness. As I stated previously, the retina is the connection point between the eye and the brain. If it's detached, person won't be able to see. Injuries of the face and neck. Can often lead to partial or complete obstruction of the airway, upper airway. Several factors may contribute to that. Blood clots from heavy facial bleeding, direct injuries to the nose, mouth, larynx, and trachea, dislodgement of teeth or dentures into the throat. Swelling that accompanies direct or indirect injury can also compromise the airway. Airway may be affected when the patient's head is turned to the side. Possible injuries to the brain or cervical spine can also exist. The face and neck is highly vascular, so there can be a lot of blood loss that occur in these areas. Swelling may be more severe. Skin and tissue in these areas have rich blood supply. Blunt injury can cause hematoma. And a hematoma is a contusion. It's just that it's an arterial vessel that's bleeding and it causes swelling, visible swelling and discoloration. Dental injuries. Mandible fractures are common. Most injuries are the result of vehicle collisions and assaults. Signs of mandible fractures include misalignment of the teeth, numbness in the chin, and inability to open the mouth. It is a painful fracture, and it takes a lot of force to fracture the mandible. To break your jaw, it requires a lot of force, especially the mandible. Maxillary fractures are usually found after blunt force high energy impacts. Signs of maxillary fractures include massive facial swelling, instability of facial bones, misalignment of teeth. Fractured and avulsed teeth are common following facial trauma. Now, scene size up. Scene safety. Observe for hazards and threats, assess for potential violence and environmental hazards. Eye protection and face masks are standard. Determine the number of patients. Mechanism of injury specific to trauma, nature of illness, medical. Assess the scene. Common MOIs for face and neck injuries include motor vehicle collision, sports, contact sports, falls, penetrating trauma, blunt trauma. Once we have completed the scene size up, the next phase of the assessment is a primary assessment. It focuses on identifying and managing life-threatening concerns. Threats to XABCs must be treated immediately. When there is life-threatening external hemorrhage, it should be addressed before airway and breathing. Form a general impression of the patient and the environment. Look for important indicators about the seriousness of the patient's condition. Injuries may be very obvious or hidden. Control blood loss with direct pressure. Consider the need for manual spinal stabilization. Check for responsiveness using the AVPU scale. Airway and breathing. Ensure a clear and patent airway. You don't have an airway, nothing else matters. If the patient is unresponsive or has significantly altered level of consciousness, consider properly sized oropharyngeal airway. And to determine if an airway is required, you must look at the patient's level of consciousness, whether or not a gag reflex is present, and whether or not the patient has poor chest rise or no chest rise. Make sure you assess for your indicators. Quickly assess for adequacy of breathing, palpate the chest wall for decap BTLS, splint or otherwise restricting chest wall motion is contraindicated. So splinting or otherwise restricting chest wall motion is contraindicated. So don't do anything that is going to restrict movement of the chest. Circulation. Quickly assess pulse rate and quality. Determine skin condition, color, and temperature. Check capillary refill time. Look for significant bleeding and address it if present. And after your ABCs, you need to answer some questions. What is the patient's GCS? Do you need to do a rapid scan or focus? Is it a load and go patient or stay and play? So transport decision. Consider quickly transporting patients with airway or breathing problems or with significant bleeding. Consider ALS backup. A patient with internal bleeding must be transported quickly for treatment by a physician. Signs of hypoperfusion imply the need for rapid transport. So if they're showing signs of shock, rapid transport is a must. The patient who has a significant MOI, but whose condition appears stable, should be transported promptly. Like the burn patient, the MOI was significant, but the patient appeared stable. The patient requires rapid transport. Any significant blow to the face or throat should increase your suspicion of spinal or brain injury. Now, once you have packaged your patient and the patient is in the back of your unit, if the patient can talk, you need to talk to your patient. Get your history, get your vital signs after. If the patient is not talking, vital signs first, consider physical findings, then think about who is present on location that can give you information about the patient. And information can come directly from the patient, from friends, family members, or bystanders. So investigate the chief complaint. Obtain a medical history. Be alert for injury-specific signs and symptoms. Be aware of pertinent negatives. Get a sample history from the patient or from friends and family. Secondary assessment. Physical examinations. If multiple systems have been affected, start with an assessment of the entire body. Look for DCAP, BTLS. Do not delay transport to complete a thorough physical examination. In a responsive patient with an isolated injury with limited MOI, consider focusing on the isolated injury, the patient's chief complaint, and the body region affected. Ensure that control of bleeding is maintained and note injury location. Inspect open wound for any foreign matter and stabilize impaled objects. Use both your eyes and your hands. Assess all underlying systems. When evaluating the eyes, start with the outer aspect and work toward the pupils. Examine the eye for any obvious foreign matter. Visual acuity is a vital sign of the eye. So you can check their central vision and you can check their peripheral. Look for discoloration, bleeding, redness, eye symmetry, and pupil size and reaction to light. For your vital signs, assess vital signs to obtain a baseline. You must be concerned with visible bleeding and unseen bleeding inside a body cavity. With facial and throat injuries, baseline information is very important. Use appropriate monitoring devices. After the secondary assessment, next is your reassessment. Repeat your primary assessment. Reassess vital signs and the chief complaint. Reassess the patient's condition at least every 5 minutes. If they are unstable, 15 minutes if they are unstable. Interventions provide complete spinal immobilization if necessary. Maintain an open airway Be prepared to suction and consider an oropharyngeal airway. So your airway management skills need to be on point for these patients. Whenever you suspect significant bleeding, provide high flow oxygen, control significant visible bleeding. If the patient has signs of hypoperfusion, treat aggressively for shock and provide rapid transport. Communication and documentation include a description of the MOI and the position in which you found the patient. Now, let's look specifically at emergency medical care. So, treat soft tissue injuries to the face and neck the same as soft tissue injuries elsewhere on the body. Assess XABCs and life threats first. Always look for your life threats first and address them. Follow your standard precautions. In the absence of life-threatening bleeding, first open and clear the airway. Avoid moving the neck in patients that you suspect cervical spine injuries. Control bleeding by applying direct manual pressure with a dry, sterile dressing. Use roller gauze wrapped around the head to hold a pressure dressing in place and try not to wrap too tight. So we don't want to bandage the head too tight. We just want to bandage it enough to keep the dressing in place because there's going to be risk for swelling. Do not apply excessive pressure if an underlying skull fracture is suspected. Cover exposed brain, eye, or other structures with moist, sterile dressing. So if brain tissue or eye, the part of the eye that should be inside the body is out, then we need to use moist dressing. Apply ice locally to injuries that do not break the skin. Do not put ice directly on the skin, so you may have to wrap it in something. For soft tissue injuries around the mouth, check for bleeding inside the mouth. Physicians can sometimes graft a piece of avulsed skin back into position. If you find portions of avulsed skin, wrap it in a sterile dressing, place it in a plastic bag, keep it cool, but do not place directly on ice, label, and deliver to the emergency department. If the avulsed skin is still attached in a loose flap, place the flap in position as close to normal as possible. Hold in place with dry, sterile dressing. For injuries to the eyes, eye injuries are common, particularly in sports, can produce lifelong complications, including blindness. After an injury, pupil reaction or shape and eye movement are disturbed. So when there's an injury to the eye, the pupil will not react properly to light, and the shape of the eye might change, and the movement of the eye may be altered. Treatment starts with a thorough examination. Always use standard precautions. Take care to not aggravate any problems. Look for abnormalities or conditions that may suggest the nature of injury. For foreign objects, the orbit protects the eye from penetration of large objects. Even a small object may produce severe irritation. Irrigation with sterile saline solution will frequently flush away loose particles. And when you're irrigating the eyes, avoid cross-contamination. So always flush from the nose side of the eye towards the outside to avoid flushing material into the other eye. A foreign body will leave a small abrasion on the conjunctiva. Gentle irrigation may not wash out foreign bodies stuck to the cornea or lying under the upper eyelid. So you may have to use a Q-tip, wet the tip with some saline, and then use that Q-tip to get the foreign body. Foreign bodies may be impaled in the eye. Bandage the object in place to support it, and cover the eye with a moist, sterile dressing. And when it's an impaled object in the eye, you need to cover both eyes. And you do not travel with this patient in an upright position, because when they're upright, that will increase the pressure inside of the eye, which can aggravate the injury. So cover the eye with a moist, sterile dressing. Surround the object with a donut-shaped collar. When you see or suspect an impaled object in the eye, bandage both eyes with soft, bulky dressing to prevent further injury. And you're bandaging both eyes because the nerves that control the movement of the eye is in pairs and they work together. So if you look to the left with your left eye, the right eye will also look in that direction. So that if there is movement of the uninjured eye, it will cause movement of the injured eye. That's why we cover both. Burns of the eye stop the burn and prevent further damage. Chemical burns usually caused by acid or alkaline solutions. Flush the eye with water or saline. Direct the greatest amount of irrigation solution or water into the eyes as gently as possible. I have different methods for that. Chemical burns, you may have to force the lids open, flush from the inner to the outside corner. If the burn was caused by an alkali or strong acid, irrigate continuously for at least 20 minutes. After irrigation, apply a clean, dry dressing to cover the eye and transport. For thermal burns, during a fire, the eyes will close to protect from heat and the eyelids will burn. Transport promptly without further examination. Cover both eyes with a sterile dressing, moisten with sterile saline, and apply eye shields over the dressing. Light burns. Infrared rays, eclipse light, and laser beams all can cause significant damage. Retinal injuries caused by exposure to light are generally not painful, but may result in permanent damage. Severe conjunctivitis usually develops with redness, swelling, and excessive tears. Lacerations require very careful repair to restore appearance and function. Bleeding may be heavy, but it usually can be controlled with gentle manual pressure. If there is a laceration of the globe itself, applying no pressure to the eye. On rare occasions, the eyeball may be displaced from its socket. Do not attempt to reposition it. Cover the eye and stabilize it with a moist, sterile dressing. Cover both eyes to prevent further injury. Have the patient remain supine, and I've explained why that is done. When they're upright, it increases the pressure inside of the eye, and that can make the injury worse. So keep them flat. Blunt trauma, high FEMA obscures all parts of the iris. An orbit fracture is a fracture of the bones that form the eye floor and support the globe. Retinal detachment is often seen in sports. Eye injuries following head injury. Signs and symptoms of a possible head injury: one pupil larger than the other, eyes not moving together, failure of the eyes to follow your finger, bleeding under the conjunctiva, protrusion or bulging of one eye. Blast injuries, signs and symptoms range from severe pain and loss of vision to foreign bodies within the globe. If there is a foreign body within the globe, do not remove it. If only one eye is injured, follow local protocol. If the patient has severe swelling, do not force the eyelid open to examine it. For contact lens and artificial eyes, do not attempt to remove contact lenses unless there is a chemical burn. To remove a hard contact lens, use a small suction cup. To remove soft contact lens, place 1 or 2 drops of saline in the eye, pinch the lens, between your thumb and index finger and lift. And that's a demonstration of that process. Or this is a demonstration of that process. For nosebleeds, epistaxis are a common problem. One of the most common causes is digital trauma. Anterior nosebleeds usually originate from the area of the septum and will bleed slowly. If it's a posterior nosebleed, it's usually more severe and often cause blood to drain into the throat, which is why we don't want them to lean back. Blunt injuries to the nose may be associated with fractures and soft tissue injuries of the face, head injuries, and or injuries to the cervical spine. Assess the nose structure for injury. So you need to assess the nose for injury. Patients with severe nasal injury may also have cervical spine injury. Cerebrospinal fluid may escape down through the nose following a fracture at the base of the skull. Control bleeding by applying a sterile dressing. Injuries of the ear, divided into 3 parts: external ear, middle ear, and the inner ear. And that's a diagram of it. Ears are often injured, but they do not usually bleed very much. In case of an ear avulsion, wrap the avulsed part in a moist sterile dressing and put it in a plastic bag. Tympanic membrane rupture, patients will report severe ear pain, difficulty hearing, or ringing in the affected ear. For the tympanic membrane rupture continued, may be caused by insertion of objects too far into the ear. Children place foreign bodies in the external auditory canal. Clear fluid coming from the ear may indicate a skull fracture. For facial fractures, typically result from blunt impact. Assume a direct blow to the mouth or nose has caused a facial fracture. Other clues include bleeding in the mouth, inability to swallow or talk, absent or loose teeth, loose or movable bone fragments. Facial fractures alone are not acute emergencies unless there is serious bleeding. Plastic surgeons can repair the damage to the face and mouth if the injuries are treated within 7 to 10 days. Swelling can be extreme within the first 24 hours after injury. For dental injuries, they can be traumatic to the patient. Bleeding will occur whenever a tooth is violently displaced from its socket. Apply direct pressure to control bleeding. You may need to consider suctioning. Cracked or loose teeth are possible airway obstructions. Save and transport an avulsed tooth. Handle it by the crown rather than the root. Place the tooth in storage solution, cool milk, or sterile saline. Notify the hospital. Reimplantation is recommended within 20 minutes to 1 hour after the trauma. For injuries to the cheek, you may encounter an object impaled in the patient's cheek. If you are unable to control bleeding, consider removing the object. Provide direct pressure on the inside and outside of the cheek. The amount of bandaging should not occlude the patient's ear passage. Injuries of the neck contains many structures that are vulnerable to injury by blunt trauma. The upper airway can be compromised, the esophagus can be injured, the carotid arteries and the jugular veins, the thyroid cartilage, the cricoid cartilage, and upper part of the trachea. And the trachea is a structure. If it is collapsed by blunt force trauma, it will not spring back into position. So if the trachea is compromised from blunt force trauma, it doesn't pop back into position. Blunt injuries, any crushing injury of the upper part of the neck is likely to involve the larynx or trachea. It can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, and the leakage of air into soft tissues of the neck. We call that subcutaneous emphysema. So subcutaneous emphysema is a characteristic crackling sensation produced by the presence of air under the skin. Complete airway obstruction can develop rapidly. Consider ALS support early. Consider spinal motion restriction. For penetrating injuries can cause profuse bleeding from laceration of the great vessels in the neck. Injuries to the carotid and jugular veins can cause the body to bleed out, exsanguination. Injuries to these large vessels may also allow air to enter the circulatory system, which can lead to air embolism and cardiac arrest. Direct pressure will control most bleeding. For laryngeal injuries, blunt force trauma to the larynx can occur when the patient is unrestrained in a vehicle and they strike the steering wheel. Can occur in snowmobile accidents, which involve clotheslines. The larynx becomes crushed against the cervical spine, resulting in soft tissue injury, fractures, and/or separation of the fascia. Penetrating or impaled objects in the larynx should not be removed unless they interfere with CPR. So only if there's an airway issue. Stabilize all impaled objects if they are not obstructing the airway. Signs and symptoms of larynx injuries include respiratory distress, hoarseness, pain, difficulty swallowing, dysphagia, cyanosis, pale skin, sputum in the wound. Subcutaneous emphysema, bruising of the neck, hematoma, bleeding. To manage a laryngeal injury, provide oxygen and ventilation as needed. Apply a cervical immobilization device if it is necessary. And that would bring us to the end of this chapter.